Hello, everyone, and welcome to the first What's New of this year's BCCSU Addiction Nursing Fellowship cohort. My name is Emma Garrett, and I'm one of the co-directors of the Addiction Nursing Fellowship, and I also work at St. Paul's as a clinical nurse specialist for the Road to Recovery program. So today we have Michelle Couper, who is presenting a talk on myth busting, smoking versus injecting opioids. Michelle is a registered psychiatric nurse who is a settler working and living on the unceded territories of the Silks Nation. Currently is a team lead for the IOT clinic and supervised consumption site at Outreach Urban Health in Kelowna. When she's not at work, she can be found hanging out with her family, yellow lab, many cats, and enjoying opportunities to hike, bike, and ski in the Okanagan. She'll tell you a bit more about the photos she has in her presentation. We've had a bit of a tech issue with like the little microphones getting pressed. So if you hear anything funny, we might run around or just take a look and see if there's a red light. For folks joining online, thank you so much for joining us. You can put any questions you have in the chat, and for folks in the room, we'll have a Q&A period at the end. Over to you.
Thank you. Like Emma said, my name is Michelle Couper, and I am a registered psychiatric nurse working in the field of addictions. I'm grateful to be part of this addictions nursing fellowship program. My background, as was mentioned, is as a team lead for an injectable opiate agonist therapy clinic and a supervised consumption site in Kelowna, BC. And you'll see throughout the presentation, I have some pictures from my recent trip into the Rocky Mountains. And I added them because they showcase the beauty of this land that we're on today. I'd like to start today with a land acknowledgement. I would like to respectfully acknowledge that we are situated on the traditional, ancestral, unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I come with respect for this land that I am on today and for the people who have and do reside here. I would also like to acknowledge that I spend most of my time in the interior on the traditional, ancestral, and unceded territories of the Syilx Okanagan people, where I live, work, and play. Technical difficulties. I'll get it. It might just take me a couple slides. So before we jump into the subject matter, I would just like to recognize that the toxic drug crisis disproportionately affects the Indigenous population. This issue is a sensitive one, as the impact of the crisis reaches far. I will be mentioning statistical data referring to overdose deaths. And when addressing this, we need to remember that we are referring to people and not numbers. When talking about the impacted lives and the ones that we have lost, we need to remember each person's name and their story. A son, a daughter, a brother, a sister, spouse, father, or mother, and that they have people who love them from their family or their chosen community. The impact of this crisis has been felt by many. I have no conflicts of interest to disclose. So the outline for today includes delving into questions surrounding the upswing of people smoking opioids versus injecting. I have two myths that I feel needs exploring. One with the misconception of not being able to overdose by smoking substances, and the other that smoking substances is safer than injecting substances. We will also look at what we have done in BC to help dispel these myths. I will also touch on some ideas to improve practice in the future. So myth number one, I didn't think I could overdose by smoking. These words came from a person who had just received naloxone in the backseat of my car. They had chosen to go to detox and requested support with a ride to get there, but had smoked a significant amount of down before we left. Once he was rousable, he reported he had never overdosed before and never received Narcan. This interaction actually shook me to my core. I needed to do some digging. Where were people getting their information? Was it word of mouth? Or were they just assuming? What did the research say? The second myth came about when I asked a client why they chose to smoke their substances rather than inject. One person simply said, it's safer to smoke. Once again, this posed more questions for me. What are the perceptions of people who use drugs? Why do they feel like it's a safer option? What do they mean by safer? Are they referring to overdoses, or are they referring to the lower instance of blood-borne infection and abscesses? What do the clients know about harms from smoking drugs rather than injecting? What education is out there to keep people safe when they use illicit substances? And then what resources are out there for people to draw on? Once again, more digging required. Let's take a look at the history of the overdose crisis over the past 10 years. So 474 apparent illicit overdose deaths happened in 2015, which was a 30% increase from the year before. Then in April of 2016, the provincial health officer declared public health emergency here. According to the coroner's report, the number of deaths from unregulated drugs continued to climb. In 2018, there was 1,565 deaths. 2020, it was up to 1,780. And by 2023, it was 2,588. Driven by the increasing unpredictability and toxicity, there was a change to the illicit supply between 2015 and 2020, where we saw a rise in the synthetic opioids, driving that rise in overdose deaths. From 2020 to the present day, we see that there has been a rise in the popularity of smoking opioids. Circling back to myth number one, I didn't think I could overdose by smoking. So for this, I was looking for data on the prevalence of smoking opioids and the increase of overdose deaths. As we're looking at the mode of consumption, I was curious to see when that switch to smoking started. And according to the BC Coroner's report, smoking was the leading mode of consumption in 2021. In the time period of 2016 to 2021, injection declined to only 20% of consumption and smoking increased to 56%. The popularity of smoking just continues to rise. This leads us to the question at hand. How is it that a person who uses opioids thinks that they're unable to overdose by inhalation? Where are those gaps in education and where are those gaps in service? Also looking at the most recent coroner's report for BC, it shows a picture over the last 2 years that the majority of overdose deaths are from smoking. This one graph does show a bleak picture. If the person who was smoking was unaware they could overdose, they might be using in an unsafe manner and not knowing the inherent risks. These statistics tell the tale that you can overdose and pass away from smoking your substances, tying the information back to that myth number one. This was an article from the United States from 2022, where they noted that there was more than 109,000 drug overdose deaths occurred in that country. And 80% of them were from smoking. In the article, the researchers spoke about the lack of harm reduction support for people who smoke opioids, noting that some of the needle exchange programs would exclude safe smoking supplies. They also noted the increase of deaths related to stimulants with opioids. So recommendations in this article included more education about OD risk, more access to harm reduction supplies, and more outreach with harm reduction supplies as well. Another study from the United States, this one was conducted in Arizona, and they were looking at the years 2017 to 2022. The study focused on people who use the counterfeit oxys, they called them blues. And at the time, there was a lot of drug seizures of these particular pills in that area. And they did a lot of drug testing on them to find out the strength of the oxys. And they noted that the strength of the pills varied greatly from 0.03% fentanyl in a pill to 5% fentanyl in a pill, which would increase the likelihood of overdose. The study included participants' perception of overdose risk when they're smoking. The article explored the questions, why the preference to smoke, and what the perceived overdose risk with the consumption method was. So they identified quite a few themes in this particular article, and we'll just go through them right now. One of them that we have to remember that all these themes were clients' perceptions. They're not necessarily research-based. So the client perception was smoking the route of administration as protective against overdose. So they felt that there was a decreased risk when smoking because you're not placing the drug directly into your bloodstream, you're smoking it instead. So drug market conditions was another theme that came up. So the cost of pills had decreased. There was more availability of those pills. And they also noted the changing drug supply. So heroin, Vicodin, Percocet, and Fent powder, they just weren't as readily available, if not at all. People were having a hard time finding them. Dosing strategies. People mentioned that they could take a puff off of the amount that they have in their pipe and then wait a little bit before hitting it again. They're reducing their risk of overdose. Then tolerance and life experience of using opioids. Some people talked about their tolerance and not having overdosed for a long time as a protective factor against overdose. Then there's personal vulnerabilities related to mental health and physical health. And people felt that both physical and mental health would increase your likelihood of a drug poisoning. Polydrug use. So increase the likelihood of OD using multiple substances, including alcohol, benzodiazepines, and/or stimulants. Another one was protective practices of take-home naloxone and looking out for each other. So using with a friend or having a naloxone kit close were their protective factors. The last one I thought was quite interesting because there was differing answers. So the role of prior overdose in assessing current risks. Some people felt that they would not overdose again because they had overdosed in the past or witnessing other people overdose. And other people said because of their overdoses in the past, they have an increased risk of overdose. So it seemed to be very different. Even though people who use substances feel like smoking their substances protect them from overdose, the researchers also noted, although smoking may be viewed as protective, it's important to acknowledge that rapid absorption of fentanyl through the lungs results in a near immediate onset of effects, contributing to the likelihood of overdose due to its high potency and narrow therapeutic window. So we have to remember that these are perceptions and not the reality. So, myth number 2. It's safer to smoke rather than to inject. Let's look at a couple research articles that focus on the voice of the people who use substances. So I chose this study because it delved deeper into the harm-related injection, in the harms related to injecting and how they differ from identified harms from smoking. The sample size was 563 people, and the people reported smoking or injecting fentanyl in the previous 3 months before the questionnaire was handed out. Questions in the survey were on overdose, soft tissue infection, endocarditis, emergency room visits, and hospital stays. And as we can see, harms were identified, definitely less harms for smoking, but some of them are quite similar. Both modes of consumption do pose a risk of overdose. This is a local study from 2021 based on the harm reduction survey. It's a province-wide survey that was sent out to overdose prevention sites and supervised consumption sites across the province. People who use substances were asked, among other things, why they chose their mode of consumption and what they perceive as their overdose risk. Results were 47.6% of people preferred to smoke due to safety reasons. 14% believed they were at lower risk for OD. 12.6% believed they were less likely to get a bloodborne infection. 11.2% believed they were less likely to get other infections. And 9.7% believed smoking helped with dosage control. This research was also done locally in 2024 to help us understand the perceptions of overdose by people who smoke drugs. Themes identified in this particular article were the unpredictable strength of the illicit drug supply, cross-contamination when using more than one substance. Some of the people stated that sometimes they get confused about the substance they use because they have multiple substances and they use an opioid rather than a stimulant when they were planning on using a stimulant. Another thing was sharing of safer smoking equipment. And some people mentioned that they would share their equipment with their friends, but they were unaware that their friends were smoking something different. So understanding the client's perceptions helps us to understand the needs of the clients, so to create better systems to combat harms. Looking at how we have addressed this issue, we need to answer the question, what have we done so far? So we have introduced harm reduction strategies. Society has also instituted harm reduction in everyday life. Choosing to wear sunscreen outside on a sunny day, wearing a helmet when riding a bike, seatbelts when in a vehicle, and following the posted speed limits. Those are all types of harm reduction. When understanding the harms of chronic opioid use and giving people the autonomy to make choices for themselves, we as healthcare providers working in this field adapt a harm reduction approach to services. According to the BC CDC, the definition of harm reduction is a set of principles, practices, and approaches to care that aims to minimize negative health, social, and legal impacts associated with sexual activity, sex work, illicit and licit substance use policies, and drug laws. Harm reduction is an integral component of the health promotion and illness prevention, treatment, and care continuum, encompassing community actions, service delivery, programs, and policies. What have we done in BC? Our harm reduction here in BC started in the late 1980s. In 1989, the first needle exchange program was started because at the time HIV was rapidly being spread by injection drug users due to sharing of needles. Then we saw in 2002, Dr. Peters Center was the first supervised injection site to open up in Vancouver. In 2003, Insight opened up, and it was the first official supervised consumption site in Canada having a Health Canada exemption. From 2005 to 2008, SCORE project started. That is the Safer Crack Use, Outreach, Research, and Education project in Vancouver, and they were handing out glass pipes to people who smoke crack. The government followed suit in 2008 by handing out crack mouthpieces, and that's that little piece of vinyl that you put on the end. And in 2011, they added the glass pipes to their distribution. By 2012, overdoses were increasing, and BC CDC Take Home Naloxone project, Take Home Naloxone program started. In 2017, that was the start of the drug checking program in BC. And by 2018, there were 31 observed consumption sites opened across BC. It was not until 2020 that the BC CDC introduced safer smoking supplies to their list of harm reduction. That included glass stems, filters, push sticks, and those glass bubbles. Over the next few years, observed inhalation areas started popping up, usually in tents outside OPSs and SCSs. And finally, in 2021, a temporary indoor inhalation site opened up in Victoria. Let's do a deeper dive into the workings of an overdose prevention site or a supervised consumption site. The services might look a little bit different in different ones that you go to. The staffing model can differ greatly from a peer-run site to a site that has run by nurses or social workers and everything in between. There are mobile sites, standalone sites, and sites that are embedded into supportive housing, community resources, and some shelters. The primary role is to respond to drug poisoning events, supply harm reduction supplies, and the staff will also provide education about safer injecting. It's a safe, non-judgmental place where human connections start. Staff are able to connect people to community services for medical, mental health, or psychosocial issues. The OPS here at St. Paul's was opened in 2018 in response to the identified need of establishing a safe place for the patients to use their substances. It was identified that many clients would use in unsafe manners, such as share their needles or use in bathrooms, and they would often leave the hospital AMA, so against medical advice, because they weren't able to use substances on site. Implementing an OPS in the hospital decreased overdose rates, provided clean equipment, and supported the patients to remain in the hospital for the duration of their medical care. In response to the increasing of overdose deaths due to inhalation and the preference of people to smoke their substances, supervised inhalation was added in early 2024. It's located in a tent next to the injection area. A report released July of this year From May 13th, 2024 to July 18th, 2025, there were 16,755 unique visits, with 83% of these involved inhalation as the primary method of substance use. Recently, the hours were extended until midnight to address the needs of the patients. In late 2023, 2 indoor inhalation services were launched. One in Victoria, the temporary inhalation service that opened in 2021 moved into its permanent home in the Harbour Supervised Consumption site. And Interior Health, they opened 2 smoking booths in the Kelowna Supervised Consumption site. The interior health services at the in the interior started in 2017 as a couple mobile sites in Kelowna and Kamloops, RVs moving between different areas of town. In Kelowna, they moved into a permanent building in 2021. The inhalation services were then added November 2023. The site has 5 injection booths and 2 indoor inhalation. And according to the latest monthly report, during the first 6 months of 2025, there was 6,680 consumption visits, and 63% of them were for inhalation. Hope to Health Clinic has a supervised consumption site located in their building with a primary care site as well. And that helps with transitions to other needed services such as wound care, chronic conditions, and/or access to substance use treatment options. This is not unlike the Kelowna site. Hope to Health supervised consumption opened up in 2020 to injection only, and in late 2024 to inhalation. Now I'd like to talk about a few harm reduction resources. Towards the Heart BC CDC Harm Reduction Program, CATIE, and also Drug Checking BC. In BC, we're all connected through the Towards the Heart BC CDC's Harm Reduction Program. On their website, they have education and resources about harm reduction, information about peer work, drug alerts, and extensive naloxone training. They also have resource lists for harm reduction sites all across BC. CATIE is another resource steeped in harm reduction. They're a Canadian resource for information about HIV and Hep C, from transmission to treatment to how to stay safe with living with HIV or hepatitis C. They have printed resources, pamphlets, guides, posters that encourage safer sex and injection habits. Interesting information on their site about hepatitis C transmission was that although sharing supplies for injection use poses the greatest risk of hepatitis C transmission, sharing smoking supplies is not without risk, as hepatitis C virus has been found on smoking supplies. Another harm reduction service in BC is the Drug Checking BC. And according to BCCSU, drug checking empowers people who use drugs to make informed decisions about substances they intend to use. The most available option for testing for fentanyl is using fent test strips. These strips are utilized by SCS and OPS staff, outreach workers, drug checking technicians, but we also hand them out with instructions so people can actually test their drugs at home. These test strips just detect the presence of fentanyl. They'll not indicate the percentage of fentanyl in your substance. BCCSU's program, Drug Checking BC, is across the province with technicians trained to use the Fourier transform infrared spectrometer, or an FTIR spectrometer. This machine will indicate the presence of various substances utilizing a very small amount of the drug, almost about the size of a grain of rice. Through the program, the results are collected, and with that information, they're able to send out drug alerts to different geographic areas to inform people about the illicit drug supply. In some areas, there's in-person checking where you can get on-site results. And other areas, there are collection sites where the results are available the following day, either via text or phone call or in person. Another thought about decreasing harms from the toxic drug supply came from Dr. Jeff Bardwell, who published an article in 2022 talking about the advantages of a smokable, safer supply as a treatment option. He refers to a recent study that suggests people use prescription opioids because of their known contents, noting it's the toxicity of the illicit supply that is leading to many drug poisonings and deaths. The question he raised is there political will for this to happen? And another option I just found out about, this safety booth. It looks to be an affordable option for health authorities or service providers to place in their sites. The company is local, out of Vancouver, and I believe they're in the pilot project stages, but it's an interesting option for keeping people safe. So what more can we do? Well, the first step is to continue to talk about stigma surrounding substance use. I was asked, is the problems stigma of the disease or stigma of the treatment of the disease? And I think one really feeds on the other. The stigma of disease makes it so people don't ask for help. They're shamed into hiding out and smoking at home and on the streets. When looking at stigma of the treatment, I feel that society thinks it just doesn't look good that we're providing a place for people to use their illicit substances, as some people don't feel they should be using those illicit substances to begin with. But we know harm reduction practices work. That there's a place that they can go smoke their substances, that in that place they'll make connections, and we also lessen the stigma that is attached. We talk about treatment options, we support them with other psychosocial issues that they might have, and that is why it works. Utilizing overdose prevention sites and supervised consumption sites to advocate for more safe inhalation spaces. We need to ask for more education for people who use substances. And we need to do more education for healthcare providers and community partners. We need to keep the conversation going. We need to bust those myths that are still hanging around. Another thought is to create more educational pieces, posters, handouts, possibly a video, with the focus on safer smoking practices and the reminder that there is high overdose risk from smoking those substances. In conclusion, we can see that myth number one is just that. It's a myth. You can overdose from smoking. The data from the current coroner's report debunks that myth. When looking at perceptions of overdose risk, the research shows that many people had differing perceptions when it came to the risk of overdose. Myth number 2, the safety of smoking. Research does show that there is a decreased risk of bloodborne infection and soft tissue infection and endocarditis when smoking substances. But the importance of harm reduction practices need to be highlighted. We can see that more people are choosing to smoke substances than inject. And I feel more education for people is needed so they understand the dangers of the unpredictable toxic supply of illicit substances and the risk of polysubstance use and the impact of sharing pipes. More safe inhalation sites are needed to support the increasing numbers of people who smoke their substances and more availability to harm reduction supplies. I feel we need to continue to share resources with people who use drugs and staff alike. Another way we can affect change is to continue to advocate for a safer supply that's a smokable option, as we need to keep up with the changing mode of consumption and the substances of choice. We need to continue to advocate for people who smoke drugs to dispel the myth, the stigma surrounding this issue. Lastly, and quite simply, we just need to keep the conversation going. Thank you. That one? That one?
Okay. Thanks so much, Michelle, for pulling together information on this super important topic, and for sharing your beautiful photos. Can you believe she took those photos? I was like, I can't believe you were there. So up here, yeah, is a survey on our What's New lecture series. It helps us as we plan for future events and to get feedback. But yeah, I'd like to open it up to questions. I'm going to take a look in the chat. There's a little, there's a thank you. And yes, Colleen, we do have a chance for a question if you want to type something in. Maybe I'll start us off too as people think about it. You reviewed what was out there. I know this is a topic of, interest for you too. If you were to design an evaluation or think about asking more questions, what would you ask people who use drugs, what they need around smoking and harm reduction?
I think the first thing I would ask is how they receive education. So are they interested in seeing a video to find out more information about something? Would it be posters that would be up in a site? Would it be pamphlets to hand out? But I think we know what we need to tell people. We just need to get that across to people. So we need to find out how they will receive that information.
Thanks. That I think it kind of links into Colleen's question, which was, did you see anything in the literature about how to respond to people who are believing those myths? And she's curious if people who use drugs have any information about how to communicate myth versus reality to other people who use drugs. So yeah, you can share a bit more on that if you want, or yeah, open to any thoughts in the room too.
Mm-hmm. Yeah, I think the best way is to find out how people receive that information. So I think that would be the next step. There is not a lot out there. I was scanning around and I did find one piece of information about smoking on the Toward the Heart program. But there was nothing in the Katie site, although Katie really does focus a lot more on HIV and injection drug use. So I can kind of understand why they wouldn't have any more resources there. But yeah.
I also did a scan. I was like, there must be something. I was like, posters, There's a lot of don't do drugs posters, but I couldn't find anything. And we know that that's not always the way that people take in information, but it's just, yeah, there is a notable gap.
Yeah.
Any questions or comments in the room? Can ask a question or just add to the conversation too. Hi.
Hi, thanks for the presentation, Michelle. In all of your readings, I was wondering, aside from, perceived safety benefits, did you come across any other reasons why people might choose to smoke their substances? Like, does it give them a different effect? Does it last longer? Does it make them less sedated? I don't know. Like anything else aside from this safety benefit?
Some people mentioned that it was more affordable as well. So when you purchase your drugs to inject, you take the whole amount of drug and you mix it up and you draw up your syringe and you end up with one shot out of your $10 or $20 amount of substance. Whereas if you're smoking the same supply, you're putting it into the pipe and you will end up, people will take a couple hits off it now and then they'll put it away and they'll come back a little bit later. So they say that it lasts a little bit longer. Yeah, that's one of the things. Also, somebody had in the literature, I didn't touch on it, but there was a little less stigma around smoking substances rather than injecting because they don't end up with the track marks. So it's not as visible to other people looking on. Yeah. Yeah.
I don't know if folks online heard that, but someone shared that there's also that matter of convenience. And I would sort of guess or assume that it wasn't something that was highlighted in any of the papers you found. But I think that's, again, it's quicker. It's not, there's less stuff you need. And
Thank you for your presentation. Do you think that, and you mentioned this related to drug supply, about available options that are cheaper and more amenable to smoking, do you think that's driving some of the shift towards smoking, or is the other way around where there's a preference that's kind of dictating what people are selling the supply?
I think that it comes down to cost. So it's really cheap for them to use fentanyl you get a big bang for your buck, really, because the strength of it is so much higher than, say, heroin. So also it's the availability as well, because the suppliers are not sourcing out heroin for people any longer. They're sourcing out the fentanyl-based product. It's very difficult to find the heroin as well. So with that, it kind of leads more towards availability.
interesting question, Lauren. Thanks. And probably another one for more exploration around those choices.
I really assume that the short half-life of fentanyl is also driving inhalation, because you can't, it's so hard. It's so hard to find pain after a while, and if you have to do that every 2 to 3 hours, it's just not possible. That's the feedback that we're seeing.
Thanks. And if folks didn't hear that online, it was just a comment about the shorter half-life of fentanyl driving smoking, because having to inject that many times would be really difficult. So, yeah. Okay, let's check online. Well, do you have any final words or comments?
Thank you for listening today. I was very nervous, tripping over my words, but I got through it, so it's good.
Did great. Yeah, and there was lots of folks joining online, so thanks to those folks. Thank you for joining us. Obviously, lots of interest in this topic. That's, you know, lots to do. I think you highlighted some really important pieces that we can take away. Yeah, for folks who haven't had a chance to fill out the survey, please do so. These are recorded. It'll be posted, and so if you want to share it around to folks, and if you have any questions, you can feel free to follow up with our BCCSU team. Oh, one last thing I was asked to share. Applications are open for the BCCSU fellowships program. So feel free to go to our website and check that out if you're interested. You can always reach out to chat about what our programs look like for the many disciplines we support. So thanks so much.
Thanks, Michelle.